Thanks very much, and congratulations to Sheila and all her colleagues for getting so many of you here, and thank you very much for inviting me to talk. Current and future treatments for lupus is quite a bit to cover in quite a short time. I just wanted to make a couple of points about what we call the unmet need, in other words, what we want to try to improve. I think one of the most convincing bits of data is the effects of lupus on being able to work. And this survey showed how patients in employment at the beginning of their lupus diagnosis find it harder and harder to continue working. So along the bottom here is time, and by 20 years after their lupus diagnosis, even though they may still be of working age, the majority have had to stop work as a result of their illness. So I think this is a very sort of practical readout of the impact of lupus on people's lives. As doctors, we tend to focus on what we call the sort of harder endpoints, and we're very aware that patients who have kidney involvement, so-called lupus nephritis, which is the most common severe, if you like, manifestation of lupus, are at risk of major problems, slightly increased risk of death and of requiring dialysis or transplant. This has improved considerably over the last 20 or 30 years, but this is recent data from Northern Europe, and showing that at 10 years there's still a considerably increased risk than we would expect for a population of patients who are usually coming at the age of between 20 and 40 with this diagnosis. We're now really quite good at holding on to kidney function. This may not mean anything to you, this number, but actually what this is normal kidney function, which means the majority of patients with this diagnosis of lupus nephritis actually retain normal renal function long term. So some things have improved a lot. But the other point I wanted to make is at 10 years, are patients still being treated? And you can see that about half of the patients are still receiving what we call an immune suppressive drug, and 3/4 are still receiving steroids. And this is sort of the bottom line of the problem that we've got. We do not have a cure for lupus. What we have is a range of drugs that we can try to use to suppress things and to manage things, and incrementally this has resulted in improving outcomes over the years, but they have been small steps. So when we're faced with a new patient, there are a number of dimensions of the treatment that we have to consider. How widespread is their lupus? How many parts of the body are affected? And for each part of the body that's affected, how severe is it? Because it may be that it's not going to have long-term consequences for that particular part of the body, be it the kidney, the lung, the heart, or whatever. So the extent and the severity of the disease. Then we have to consider, well, if we're going to advise some treatments, how's the patient going to get on with these treatments? Are they going to tolerate them? Are they going to get particularly side effects with this treatment? Are they going to agree to having this treatment? And if they do agree, are they actually going to take the treatment? And this is a particular issue for younger patients as to whether they adhere or comply with the advice that we give. And then we have to consider the longer term, and always in the back of our mind is, where are things going to be in 5, 10, 15, 20 years' time? You know, when is this patient going to want to start a family or whatever? And what is the impact of my decisions now going to be on those longer term outcomes? And then we have to consider treatments that we're targeting at the disease, treatments we're targeting to try to suppress the disease, and the whole other side of treatment of what we would call supportive care. So these are drugs, for example, to treat blood pressure, to treat vitamin deficiencies, to try to prevent the various complications we might cause by the lupus treatments, and various other interventions such as education and other aspects of support that go into a sort of broad management package. So there are a lot of dimensions, and of course I haven't touched on cost and whether we, particularly for some of the newer drugs, whether we can persuade the system to pay for them, which is an issue. So where are we? Broadly, we talk about patients with mild disease, which tends to be skin, maybe joint. We talk about moderate disease, where there may be involvement of internal organs. We talk about severe disease, which is really characterized by a type of lupus which is going to damage irreversibly an important organ such as the kidney or the heart. And for mild patients, we talk about anti-inflammatory drugs. These are drugs like ibuprofen, non-steroidals, which suppress pain and inflammation in joints. We talk about topical agents in the skin, and a family of drugs called the anti-malarials, of which chloroquine or hydroxychloroquine is the most widely used. And we rarely would use oral steroids for any length of time in this group. Patients with moderate disease usually end up on steroids. They're on antimalarials as well, and often they will be given immune suppressives, but the main role of the immune suppressive in this category is to try to minimize the steroid dose. So it's there really as what we call a steroid sparing drug. And for those with severe disease, they will all be on immune suppressives, and they may well be receiving higher dose steroids both by mouth and by intravenous injection, and usually on antimalarials as well. So this is the sort of standard spectrum of drugs that we use. Steroids are a wonderful drug. Before steroids, in the late 1940s, early 1950s, there really were not any effective treatments for lupus. And one of the problems is steroids work so well, but they have so many side effects, both short and long term. And because they're quite an old drug, it's actually quite hard to study steroids in a scientific way and work out which dose should be used. No drug company is going to fund that sort of study. And frequently the question we're asked is how much steroid we should use. And the refrain from all of you and from doctors is, well, less steroid. The problem is that there is not huge consensus of how much steroid should be used. I was involved in a lupus nephritis trial, which was taking place around the world. And we looked at regimens commonly used in the US, which would start up here. This is about, we're dosing here according to body weight, but this would be about 60 or 70 milligrams a day, quite a high dose. Whereas in Europe, we tend to start about half that, between about 30 and 40 milligrams a day. But these arrows indicate some intravenous steroid, which they don't like in the US very much. So for the trial, we actually compromised, and there were 3 of us from the US and 3 of us from Europe. We went for halfway house, and we started halfway between. But it just shows you some of the discrepancy in opinion. We were able, though, to persuade a drug company to do a steroid trial. They were mainly interested in testing their immunosuppressive, but we persuaded them to use these 2 different steroid regimens, the sort of higher US dose and the lower EU dose. So we had a standard regimen and a reduced regimen. And if you look at these 2 columns here, this is really talking about a response, complete or partial, and there was a trend in favor of the standard dose, so the higher dose steroid, the trend to more responses. But if you look at this end of the slide here, SAE stands for severe adverse event. That is something that's happening to the patient that's going to take them into the hospital, usually a bad infection. And there were double the number of severe adverse events with the higher dose steroid than the standard. And this sort of crystallizes the issue we have with steroids, that if we really push the dose up, we can get slightly better responses, but the patient pays for it because they have a much higher risk of a problem. Another issue, of course, with steroids is how long do you go on for, and when should you stop? Now, for patients with the moderate disease group, you usually have a readout, such as the joints or the skin, that you can follow, and you can titrate the steroid down as low as you can. But for some patients with more serious disease, for example, in the kidney or the brain, you're really very concerned about the disease recurring, so you want to do everything you can to stop it recurring. But there is no agreement amongst doctors as to how long to treat for. And we sent round a questionnaire around the world with a scenario of a 21-year-old lady who had been in remission for 2 years with her kidney disease, and we asked doctors, what would you do? And we got an absolute equal breakdown. They'd stop, they'd keep going, or they didn't know. So that sort of summarizes some of the discrepancies. And we found differences between regions in the world, and kidney doctors tended to want to stop, and rheumatologists tended to, no, I think it's the other way around, actually. Yeah, rheumatologists tended to continue. So that's what I was going to say about steroids. In terms of immune suppressives, there are a number that we use. You will have heard of some of the names. For the moderate disease group, we tend to use methotrexate, which is widely used in arthritis, and we use drugs such as Azathioprine, and this drug, Microphenylate mofetil. But for those in the severe group, traditionally we've tended to use a more aggressive drug called cyclophosphamide, and much of the research in the last few years has been to see whether we can minimize the dose or get rid of it altogether. And this trial compared mycophenolate to cyclophosphamide in kidney disease. All patients had kidney disease and all received the steroid regimen I mentioned earlier. And really, there was no difference in response. So this was good because it meant that we have a choice. We can use cyclophosphamide or mycophenolate, and they have different side effect profiles, so we can personalize the treatment to a certain extent. But those, you may have noticed that these figures are not great, are they? We're dealing with patients with kidney disease, and whatever you're talking about in terms of patients getting better, 53, 56% is not a great figure for patients improving. And there's been a lot of thought about why our drugs are not working particularly well. And the main reason they're not working well is because of side effects. And these are the side effects we saw in this study. So over 95% of patients, pretty well everyone, had drug-related toxicity side effects. And the other key one to look at again here is severe adverse events. This is affecting a quarter of the patients. And if a patient has a severe adverse event, you stop the drugs. Well, certainly stop the immunosuppressive and reduce the steroids. And then you lose control on the disease or everything changes. So a real challenge that we have is that, yes, we've got drugs with some efficacy that work, but a lot of toxicity which is interfering with what's happening to the patient, the chance of getting better. Now, the drug industry has looked at this slide, and they've seen an opportunity here, because they've seen 45% of patients not getting better, and they think, well, we can put a drug in there and improve that. That's an opportunity for us. I think the problem is they haven't understood the reason the drugs are not working so well is not so much the drug itself, it's the side effects that patients are experiencing. However, we do have a positive result for drugs, and this is the same trial where we followed up long term. This is going up over 3 years to see which of two drugs was better at stopping the disease returning in kidney disease. And azathioprine has been the sort of standard treatment we've had really since the 1970s, and this was compared head-to-head to mycophenolate. And what we're seeing here is the proportion of patients who are flaring. So if the line went along the top, that means no relapses, and as the steeper the line, the more relapses that are occurring. And this clearly shown that the mycophenolate group in the yellow line here did better than the green group in the azathioprine. And this is a very rare event in lupus trials where actually one drug has been shown to be superior to another drug. And we may touch on trial problems a little bit later. So in terms of treating the kidney disease, we now know we can use mycophenolate at the beginning. We don't have to use cyclophosphamide. We have a choice. And then going long term, mycophenolate seems to be preferable. So the other half of my task was to talk about some future treatments. So I've sort of relabeled this with newer and future treatments, because around about 2000, the year 2000, there's been a big scene change in lupus. Up to 2000 was really the drugs that I've been talking about, but since 2000 is a new era. And that era is characterized by two things. It's characterized by drugs called biologics, which then is a new category of drugs. And the pharmaceutical industry has finally noticed lupus. And the pharmaceutical industry is very important because they have a lot of money. And we need them to invest in lupus. Now, of course, I mean, they're there to make money, but if they do not invest, there won't be better treatments for lupus. So they are important. So I apologize for the complexity of this, but to understand biologics, you do have to make a leap into understanding a little bit of the science of what's going on in lupus. And lupus is a problem with the immune system, the body's immune system that defends us from infection. And in many reasons, the reasons we're here is because our ancestors survived all the great infections of the past, smallpox and plague and so on. So we've got very sophisticated immune systems which are going to protect us from those infections, but the downside is they render us susceptible to diseases such as lupus. The immune system broadly has cells that you can see down the microscope, white blood cells, and then it has a whole lot of soluble stuff in the blood, messengers where one cell talks to another cell, and antibodies which are sent out and cause damage to tissues. So the two cells that are particularly important, so-called the T cell and the B cell. The T cell is sort of the conductor of the orchestra, if you like, is the intelligent cell type that sort of learns what's going on and tends to direct the immune system. The B cell is a key stage in making antibodies. And this communication, we call it an interaction between T cells and B cells, really lies at the heart of what of what goes on in the immune system. So the B cells, having been instructed by a T cell, if you like, will then go on to make a factory that makes antibodies, and then these antibodies can cause trouble. In lupus, can cause trouble, and this is just a representation of a bit of the kidney, with the antibodies going into the kidney and causing damage. All of these boxes here are drugs. These are all new biologics, and the point about a biologic is that it's focused and goes and does one thing at a molecular level. So you can see that, for example, this drug here, atacicept, blocks this little messenger here, and this drug here, abatacept, blocks this interaction between these two surface molecules here. You may have heard of rituximab, and that works by killing B cells by attacking this marker here. And bulimimab, we'll talk a bit more about, blocks another messenger that binds here. So biologics are targeted. They do one thing, and they're inherently safe. The problem with steroids and the drugs I talked about before is they have lots of actions. So they have actions on what you want them to do, and they have lots of actions on what you don't want them to do. Biologics are inherently targeted therapies. And all of these boxes represent a pharmaceutical company that has got a development program in lupus costing tens or hundreds of millions of dollars. It's very, very expensive. And unfortunately, they've not done very well. So if we just take lupus nephritis as being one category that drugs, all of these drugs are in trials in lupus nephritis. This trial was negative. This trial was stopped because of some infection problems. This trial is in progress. This was stopped because of infection problems. This trial was negative, meant it didn't show what it was meant to do. This trial was stopped because of safety concerns. This has been really, really challenging. And this is a problem because these drugs work. You know, they have biological efficacy. They've been shown to work in experimental models, experimental systems, and they do work in humans. But demonstrating they work without lots of toxicity has proved very, very difficult. I put this up because it's a nice name, Tweak, which is a new messenger which was discovered relatively recently, and there's a company which has got an anti-Tweak, which is seeing whether it works. So, yes, we're understanding quite a lot about what targets should be gone for, and the drug companies have made these drugs to go for them, but actually demonstrating that they work in clinical trials has proved really, really hard. Now, rituximab is a drug you may have heard of. It's been around since the late 90s and has been in lupus since about 2000, 2001. And it works for some patients. And we've been using it. These graphs at the bottom were some published experience from about 7 or 8 years ago now, but demonstrating about 80%, about 4 patients out of 5, were getting a response to rituximab. And this is data from France, from a registry in France, and this is data from a Spanish and UK registry, showing that the majority of patients who were given rituximab in these studies were getting a clear benefit. The problem is Genentech, who make rituximab, did a trial. They did 2 trials, and they both didn't work. And they didn't work because they were overambitious. They were trying to show too big a treatment effect, and they didn't work because they were trying to give them to all patients, and a lot of patients were just going to get better anyway. Whereas in the day-to-day rough and tumble of clinical medicine, we tend to reserve rituximab for the patients who are not doing well on standard therapy. So bulimimab is sort of related to rituximab. I put up the target a little bit earlier. It affects the B cell, and it stops the B cell from moving into these antibody-producing cells. And that has got through. It has had a successful program, at least for non-renal, non-kidney lupus. But the reason they got there was they did really big trials, 800-patient trials, and they did 2 of them. And so they were able to demonstrate a relatively small improvement because they had so many patients in their studies. So this was a success story. It's been licensed, but we cannot use it because NICE, who are essentially the government's way of rationing the drugs that we use, have said that that degree of benefit does not justify the cost of bulimimab. And the problem we have is that in order for the drug company to do a trial to demonstrate benefit, they designed they used the drug not in the way that we would want to use it in the clinic. We would want to use it for patients not doing well with standard therapy, such as we use rituximab, whereas they designed the trial to give it to all comers, if you like, of whom most did well. So the benefit they saw was quite small. And NICE have just focused on that benefit and said you can't use the drug. So that's an ongoing debate that we're having with them at the moment. Another messenger I wanted to mention is interferon alpha. This is a tiny little messenger which cells use to talk to each other. And the point about this is that our immune system is always in contact with bugs and microbes that are around us. And interferon alpha is one of the early signals that the immune system sends to other cells. Here's a T cell and here's a B cell, to tell them to get on with it and get activated. And this system in lupus is completely unregulated. So we see far too much interferon alpha, and this is one of the reasons why if you have lupus and you have an infection, that can spark your lupus off again. And there are 3 or 4 drugs in development now that are targeting interferon alpha. None of them are available for patients. We haven't seen big studies yet, but I flag it up as a potential future treatment to block this mechanism. Because we're here on the Genome campus, I didn't think I could give you this lecture without saying something about genomics. I thought I'd show you this slide. One of the techniques that we have in the laboratory now is to look to see in a particular cell or a particular group of cells which genes are being switched on or off. So in all of our cells, we have all of our genes, 30,000 genes. And at any one time, most of them are switched off. But as the cell does whatever it wants to do, it switches on this gene and that gene and this gene and that gene. And using this sort of analysis, we can look at all 30,000 genes and to see whether they're switched on or switched off. And the color means red means on and green means off. And these are all the different genes down here, and these are a number of different diseases and healthy controls along here. Anyway, you do this sort of analysis, and you throw it all into a computer, and you say, what is special about lupus? And the computer goes through its processes and comes back with a picture, and you can see all the lupus patients aggregating here with lots of red dots all coming together. And these are all, in this particular analysis, these are all genes related to alpha interferon. So if you were to put alpha interferon into a test tube, these are all the genes that are going to be switched on by alpha interferon. So this is just an example of another way of demonstrating alpha interferon is particularly important. And you can actually go from this to doing relatively more traditional assays showing lupus patients have much more of this going on than otherwise. So that's, I apologize for the genomics. So I'm just going to close by talking about stem cells. And, if you want to get something into the popular press, you talk about stem cells. And sometimes when I have my laptop open at airports and I'm waiting to get on a plane, people look over my shoulder and say, are you doing stem cell research? So there are two types of stem cells that have been considered or have been used in lupus. The so-called hemopoietic stem cells, so these are stem cells that will allow a new immune system, or new blood if you like, to be grown. And the so-called mesenchymal stem cells, and this is a type of cell that can be programmed to do lots of different things. You can make it into a nerve, or you can make it into a bone cell, or you can make it into a kidney cell. So it's what we call very plastic in the way that it can be used for different ways. Now, this procedure using hematopoietic stem cells has been in medicine for a long time, particularly in cancer therapies, where you give drugs to kill everything off, and then you give stem cells to grow a new blood and immune system. And it's been used in lupus since about 1995, using the similar type of scientific approach where you give drugs to try to kill off the immune system. We call it ablation, and you give stem cells to grow a new immune system back. Mesenchymal stem cells are sort of flirting with lupus at the moment and aren't regular therapy, but there's a little bit of very preliminary data. So we've been following the hemopoietic stem cell program, and we took part in this back in the late 90s, but this is just some recent data. There's a European registry, and the bottom line is it doesn't work. So this focuses on only 28 patients, but a previous report, an earlier report focused on about 55 patients. There is a mortality from the procedure. It's a very aggressive procedure, but then it's given to the worst lupus patients, so that's sort of difficult to assess quite what that means. But this is the key readout. Does it cure the disease? Because the only reason for pushing a patient through this sort of procedure is if they're going to be cured. And what we're looking at here is what we call disease-free survival. And if everyone was cured, the blue line would be along like that. But you can see over time, so this is 50 months, over time, most patients, the disease comes back. So it's not curative. So really, this has gone. And we still get referred occasional patients to consider this procedure, but we haven't done it for a very long time. But I just really put this up, and I think this will be regarded a little bit to history. It's not the way to cure lupus, unfortunately. So just a slide on stem cells. These are the mesenchymal stem cells, so-called MSCs, and you can expand these cells in the test tube and probably inside patients to form something that we call Tregs. Tregs are regulatory T cells which go around the body, find places where there's inflammation, and tell them to calm down and switch off. And some people view lupus as a failure of your Tregs, a failure of your regulatory T cells. So there is some evidence that these MSCs can be transformed into Tregs, which can then go into tissues and switch off cells that are causing T cells to be activated, B cells to be activated, and antibodies to be produced. The problem with this area of medicine is that it's very emotive, and it's prone to very early, very low-grade scientific reports. And there is a Chinese literature and a Korean literature that's emerged saying that MSCs may be very good in lupus, but we're looking at this very, very critically at the moment. And this is not a procedure I see going to patients at all soon, but it's something it's a technology that's evolving that we're watching. So I just wanted to close by saying that you can have all of these drugs, and it's a little bit like playing the piano. You know, you can have all the notes, but you need to know the order in which to play them. And getting the right drugs to the right patients is a challenge. One of the changes in the last decade has been recommendations, and what these recommendations are groups of doctors and patients coming together, reviewing all the literature, reviewing their own experience, and writing recommendation statements. And what this means is that there are now standards that are available to be applied for how the drugs should be used. So this is a joint initiative between two European groups, rheumatologists and the kidney doctors, and this is a report published in the States, exactly the same, but this was rather aimed at a North American audience and this at a European audience. But this is just showing the whole field is maturing so that we can write these recommendations about standardized treatments. And I'll stop there. Thank you.